Welcome to The Explainer. Today, we're diving into a topic that's an absolute cornerstone of preventive medicine, colorectal cancer screening. We're going to break down all the different tests, weigh their pros and cons, and hopefully build a really practical framework that you can use day to day with your patients. So, why does this matter so much? Well, this number, it really says it all. Over 90%. That's the 5-year survival rate for colorectal cancer when we catch it while it's still localized. It's just a powerful, powerful reminder of why getting this screening right is so critical. And that really is the million-dollar question, isn't it? How do we find it early? The answer is all about screening people before they have any symptoms at all. And to do that, we really need to understand the tools in our arsenal, from the simple stool tests to the big gun endoscopic procedures. Each one has its own set of risks, benefits, and, of course, demands on the patient. Okay, let's jump right in. Here's our game plan. We're going to start with the why. Then we'll systematically walk through the 3 main types of tests: stool-based, endoscopic, and the radiologic ones. And then we'll wrap it all up by putting it together to help guide those real-world clinical decisions. First things first, let's just quickly nail down the why. What's the fundamental goal here? Because it's actually not just about finding cancer, it's about preventing it in the first place. So here's the crucial point. Our goal is really twofold. Yeah, we want to find existing cancer early, but what we're really doing is hunting for the precursors, those adenomatous polyps and sessile serrated lesions, so we can get them out of there before they ever get the chance to turn into something nasty. That's the real magic here. It's the difference between detection and true prevention. All right, let's start with our first category, the stool-based tests. For a lot of patients, these non-invasive options are going to be the most accessible way to even start the screening conversation. So let's compare the 2 main fecal occult blood tests head-to-head. The big takeaway here is that the fecal immunochemical test, or FIT, is just a massive upgrade. It's way more specific because it only detects human hemoglobin, it only needs 1 sample, and patients don't have to worry about changing their diet. That makes it way more convenient and, importantly, more sensitive than the old guaiac tests. Now, the technology has taken another really cool leap forward with this, the multi-target stool DNA FIT test. So instead of just looking for blood, this test adds a whole other layer of detection. It's actually searching for the molecular signature of the problem itself, the altered DNA that gets shed from polyps and cancers. And this slide really gets to the core advantage of this entire category of tests. It's all about convenience. You're removing these huge barriers, right? No bowel prep, no sedation, no taking a day off work. Being able to do this at home can make all the difference in whether a patient actually gets screened or not. All right, let's switch gears. We're moving from just looking for clues to direct visualization. With endoscopic tests, we're not just detecting something might be wrong. We're actually going inside the colon to find it, diagnose it, and even treat it, all in one go. So let's break down the gold standard colonoscopy. You can really think about it in these 4 key stages. It all starts with that famously challenging bowel prep, right? Then comes sedation to keep the patient comfortable. After that is the actual examination of the entire colon and, this is key, the ability to intervene right then and there, taking biopsies or just snipping out polyps on the stop. And this really lays out the fundamental trade-off with colonoscopy. On one hand, it is without a doubt our most effective test. It's got the highest sensitivity for both cancer and those precancerous polyps. It's diagnostic and therapeutic. But on the other hand, it is the most burdensome for the patient and the healthcare system, and it carries the highest procedural risk, even though that risk is quite small. Now let's compare colonoscopy to its less extensive cousin, the sigmoidoscopy. The critical difference here, and you really got to remember this, is reach. A sigmoidoscopy only looks at the distal part of the colon, the left side. And while the prep is easier and you don't need sedation, that limited view comes at a pretty serious cost. And this is the clinical consequence of that limited view. I mean, look at that number. It's staggering. 41 to 45%. That's how many colorectal cancers are estimated to be hiding out on the right side of the colon. These are the proximal lesions that a sigmoidoscopy would miss completely. Okay, finally, let's look at a totally different approach, non-endoscopic imaging. And we'll also take a little peek at what's coming down the pike for screening tech. So, CT colonography, or CTC, gives us this virtual tour of the entire colon. You still have to do a bowel prep, which is no fun, but you get to skip the sedation and the risks of an actual scope. The key limitation, though, and this is a big one, is that it is purely diagnostic. If they find anything, the patient still has to go get a regular colonoscopy to have it removed. Now, let's talk about the future, blood-based tests. I mean, the idea of a simple blood draw for cancer screening is the holy grail, right? And the data shows some real promise. Look at that sensitivity for detecting actual cancer. It's pretty good, over 80%. But then look at the number for the precancerous lesions we want to find. The sensitivity just plummets. This really highlights the current trade-off. These new tests are much better at finding cancer than they are at preventing it. So with all of these options on the table, how do we put it all together to actually guide a patient? Let's boil this all down into a high-yield comparison you can actually use in your practice. Think of this table as your clinical cheat sheet. It lays out everything: the recommended interval, the sensitivity for both cancer and advanced adenomas, and the key clinical pearl for each test. You can really see the trade-offs, right? Like the super high sensitivity of the sDNA fit for cancer comes with more false positives. And while colonoscopy is obviously the gold standard, you can see that the non-invasive options still do a really effective job if, and only if, they're done at the right intervals. So after all that, after looking at all the evidence, the different technologies, the sensitivities, the specificities, what's the ultimate takeaway for us as clinicians on the front lines? What's the bottom line? And here it is. This is arguably the most important principle in all of screening medicine. A test could have perfect efficacy, but it's completely useless if the patient won't do it. This is exactly why shared decision-making isn't just some buzzword. It's the absolute key to making a screening program work. And it's so important to remember that this field is not standing still. Not at all. We are right on the cusp of even more change. New technologies like multi-target stool RNA tests, more advanced blood-based assays, they are being developed as we speak and will very likely change our algorithms in the very near future. And this is the question that's really going to shape the future of cancer prevention. As our technology makes these tests more sensitive and less invasive, will we start to define the best test, not by its diagnostic perfection, but by how easily it just fits into a patient's life? That's the balance we're all going to be navigating. Thanks for tuning in.